we spoke about little bit of epistaxis. So how will you manage conservatively first, and after that we will go for the surgical management. Any case of epistaxis, anything, any emergency, any acute condition, first this thing, ABC, right? Airway, breathing and circulation. Okay? Have you settled down? Okay. Now, after this history, medications, all these things, everything, go for the anterior rhinoscopy and endoscopic examination. Okay? Look at the source of the bleeding. Okay? These are the things, this will be asked in your exam. Patient with epistaxis, what are the things you need to have in your hand, okay, before proceeding? You should have a proper sitting arrangements, headlight, suction, some xylometazole, oxymetazole, adrenaline solution, and all the packs and all, and electrocautery. Okay. These are the direct therapy, localizing the bleeding vessel and stopping it. You can cauterize with silver nitrate, that is the chemical cautery. You can go for a bipolar diathermy or monopolar diathermy and other things. Endoscopically, we can do many other things. And indirect therapy is nasal packing. This thing, anterior nasal packing, is the foremost important thing that being a graduate, medical graduate, you have to perform. Okay. Other things required expert intervention, but this thing you have to perform, anterior nasal packing. There are other things, posterior packing. If the with anterior nasal packing you cannot stop the bleeding, then you have to go for a posterior packing. Okay. Even after that the bleeding is not being controlled, then what will you do? You did everything possible. You gave the anterior pack, you tried cautery, you gave posterior packing, you lowered the blood pressure, everything is, after everything, even after everything, bleeding is not being controlled. Then you will go for some ligation of the bleeding vessels, right? You can start with maxillary artery, start with sphenopalatine artery. I told you sphenopalatine artery is known as artery of epistaxis, right? Then we can proceed to maxillary artery. Even if after that it is not being stopped, we can even ligate our external carotid artery. Okay. We can perform some septal surgeries, and with radiological intervention, we can go for a CT angio and embolize the vessel. Okay. So how will you do? This will be demonstrated further. This is this typical method of the posterior packing. With nowadays we do it with Foley's catheter. I will show you a video. And this is the anterior packing with traditional packing with Vaseline gauze, okay, or antibiotic impregnated gauze. We can put it for 24 to 48 hours to stop the bleeding, okay. And nowadays we do it with commercially available Merosil nasal packing, okay. We just put the nasal pack, it expands and stop the bleeding. These are the questions that will be asked. I have told you already what is anterior epistaxis. Epistaxis from the front of the nose, okay. If the bleeding comes most from your front of the nose, then it is anterior epistaxis. What are the causes, how to manage it, again and again and again I have told. If it is a posterior epistaxis, mostly from the sphenopalatine artery branches posteriorly located, okay. Most of the blood comes into the mouth, okay. So if the patient is telling that there is a bleeding and rocto golai chole asche, most of the rocto, that means it is a posterior epistaxis. So this type of bleeding mostly can be controlled with anterior nasal packing, but in few cases you have to do a posterior packing, okay. Again the same thing, but little bit different. We will start with packing. It can be massive, we need transfusion sometimes, and if there is any nasal anomaly inside, then packing will be difficult, right? So in those cases we have to intervene for other things. Now I told you that angiofibroma will be discussed a little bit detail. considering the MBBS curriculum, I will try to be as precise as possible. So this is the condition. Juvenile means it's in juvenile age group. Okay. Nasopharyngeal means the mass mostly occupy the nasopharyngeal area. It's a tumor, right? And angiofibroma means it's a kind of tumor having angio means vascular component and fibroma means fibrous component, and oma is benign tumor, right? What is the presenting feature? Lots of blood. Okay. Young male patient waking up in the morning with a pool of blood. Okay, spontaneous bleeding, recurrent episodes. We have to search if there is any angiofibroma, this kind of tumor is present there or not. Okay. What is the origin? This is an MCQ question. Mostly in the sphenopalatine foramen area. Alternate basis sphenoid or skull base area or Vidian canal, that can be also a source. Okay. If we do not remove it from the source, it will recur. Okay. It's notorious for recurrence. So, the primary blood supply is from the internal maxillary artery itself. So, this is the area, sphenopalatine area, this is the sphenoid sinus, this is the palatine bone, right? Pterygoid plate and palatine bone. This is the sphenopalatine area. From here it starts growing. Okay, it can grow mostly to the medially to the nasal cavity and nasopharynx, but laterally it can go to pterygopalatine fossa and ultimately to infratemporal fossa, right? এবার এটার অ্যানাটমিতে অনেক ডিটেল, হ্যাঁ, so I will discuss it in other class. Obviously, if you are interested, you have to pass through the basic thing first. So, sphenopalatine foramen area, it has two important nerves, nasopalatine nerve and posterior superior nasal nerve, and branches of the maxillary artery. Okay, the most important one is sphenopalatine artery. Okay, this is the classical anatomy, the cadaveric dissection, how the nerves and vessels are going, and this area is sphenopalatine foramen area, right? So how will you go through there? This is the sphenopalatine area or sphenopalatine fossa or pterygopalatine fossa. This is your maxilla, right? So endoscopically we have to pierce the maxilla, we have to cut through the posterior wall and go to that area, okay? And go to laterally and ligate the maxillary artery. Then we can control the bleeding. So it needs an expert hand. Okay. This is your external carotid artery. I told you I will ask the branches. What are the branches? External carotid artery branches. Huh? Who will volunteer? Anybody from house? Huh? Nobody. So if you do not know the branches of external carotid artery, how can I describe how to treat this kind of tumor? Okay. So I will give you another opportunity. Next class I will ask again. So this is a complex vascular network and this is the kind of tumor. Okay. Histology, I told you it's angiofibroma means it has a vascular component and a fibrous component. Okay. If the fibrous component is more, bleeding will be less. If the vascular component is more, bleeding will be more, right? How will you diagnose? Young adult male, recurrent epistaxis, and obviously there will be nasal obstruction because there is a tumor inside your nose. Other things, it depends upon the complications. Conductive hearing loss in a nasal tumor, how will it happen? If it obstructs the eustachian tube, right? Rhinolalia because of the nasal obstruction, anosmia because of the nasal obstruction, right? There is a tumor, so there will be anosmia, right? Swelling of the cheek, if the tumor comes laterally and occupies it pushes the cheek, right? It erodes the maxilla or something like that. Dactylar cystitis, if it pushes the nasolacrimal duct area. Deformity of the hard and soft palate, bulging and etc. And orbital proptosis, if the tumor goes to your orbit. Appearance, this is the kind of appearance, I will show you better. This is the better picture. It looks like this and this. Okay. So, CT scan for bony detailing, MRI for soft tissue detailing. And we will do an angiogram to see the feeding vessel. This is a classical MCQ question that will be asked. What is Hormone-Miller sign? Okay. What is this? This is the Hormone-Miller sign. This is the maxilla, right? This is the maxilla posterolateral wall, right? And see the posterolateral wall here. This is the tumor, okay? It pushing the posterolateral wall anteriorly, right? So this area is widened. This is less wide. This is known as classical Hormone-Miller sign, okay? This is the in T1-way imaging of MRI, the classical this angiofibroma. Heterogeneous intermediate signal will be there and flow voids will present. Just remember this thing, okay? And T2 you will get more detail about the pathology. So it is again intermediate to high signal enhancement and multiple flow voids will be there. This is an arteriogram. You can see this is the tumor, it's a very vascular tumor and it has a definite feeder vessel, okay? This is one of the vessels, this is another and this is little bit of other vessels are there, okay? So the main feeding vessel here is internal maxillary artery. Early stage, I am not going to that. How do you treat it? We have to go for a surgery, right? And that surgery is very difficult, okay? Difficult in the sense that it needs expertise, okay, expert hand. And apart from them, though it is not a cancer, but little bit of radiation therapy can make sometimes given if the tumor is unresectable. Patient is acutely ill, very aggressive situation, okay. And there is little bit role of chemotherapy as well and hormone therapy. Estrogens, because you see the tumor is exclusively for male. Females do not get this tumor, right? So there is a hypothesis that estrogen might be helpful. So sometimes we give the patients estrogen therapy. So that's all, and I will please start the next slide, okay. Anyone, read it out. 52-year-old male, okay. Hearing impairment, lymph node is there. And what is the provisional diagnosis? This is the question. 52-year-old male with hearing impairment and enlarged painless lymph node. Clinical and radiological picture is there, okay. Little bit difficult for you, but I am just telling you that this is the nasopharynx area, okay. So this patient can have a nasopharyngeal growth, right? And if there is nasopharyngeal growth, the eustachian tube will be obstructed. So if the eustachian tube is obstructed, then there will be conductive hearing loss, right? Because there will be fluid buildup in the middle ear. And this is the classical CT scan picture, I mean MRI picture. And if the patient is having severe hemifacial pain and deviated uvula, this condition is known, it's a syndrome. পড়াশোনা হচ্ছে না? যদি হয়ে থাকে তাহলে এই কোশ্চেনটা পারা যাবে। It's known as Trotter's triad, right? So nasopharyngeal cancer, our diagnosis, 3 risk factors. Can you name 3 risk factors for nasopharyngeal cancer? Polyp. Polyp is a risk factor. What is risk factor? Community medicine question. Smoking, right? It has high association with a virus. High association with a virus, right? Epstein-Barr virus, right? Nasopharyngeal cancer, surgery? No. First line of management is radiation and chemoradiation as well. Chemotherapy, radiotherapy, mostly radiation, then chemotherapy adjuvant or neoadjuvant. Then if there is little bit of residual disease is there, we can go for a surgery. But surgery is not the mainstay of treatment, right? Look at this. There are many pictures, right? What is this? There is swelling in both sides of the nasal septum. Septal hematoma. Last day I told you. Okay, আমি বেশি ডিটেইলে যাচ্ছি না, I am showing you the pictures, right? Here there is another swelling. in your pinna. Suppose the patient is having a history of trauma, কেউ মেরেছে. It's not cauliflower. Okay, boxer shears happens next. First, this is auricular hematoma, right? After resolving of this hematoma, it becomes cauliflower ear, or after pericarditis, episodes of pericarditis. Okay, so this is auricular hematoma, right? Here you can see a bruise mark, battle sign. কে বললো? কে বললো প্রথম battle sign? Good job. Battle sign কিসে পাওয়া যায়? Any skull based trauma, right? এটা কি আছে? Stroma with epistaxis, right? Here is এখানে anterior nasal packing দেওয়া রয়েছে. Lots of trauma, traumatic epistaxis, this one. এটা trauma, তাই তো? তো কি কি ইনজুরি আছে? How will you assess this patient? What will you do? পুরো facial laceration হয়ে আছে, তাই তো? তো lots of soft tissue injury, lots of bleeding, তাই তো? নাকটাও দেখছি পুরো ধেবড়ে ফেবড়ে রয়েছে, তাই তো? ম্যান্ডিবলটাও বোঝা যাচ্ছে না কি অবস্থায় রয়েছে. সো পসিবল দেয়ার আর মেনি বনি ইনজুরিজ, তাই তো? তো এই পেশেন্টকে বাঁচাতে হবে ফার্স্ট, রাইট? দেন উই উইল গো ফর দ্য ডেফিনিটিভ ম্যানেজমেন্ট, রিপেয়ারিং অল দিস থিংস. এই পেশেন্টকে বাঁচাতে গেলে কি করতে হবে? এয়ারওয়ে সিকিউর করতে হবে আগে, তাই তো? এয়ারওয়ে কি করে সিকিউর করবি? ট্র্যাকিওস্টমি করতে হবে, রাইট? বিকজ মুখে কোনো এয়ারওয়ে যাওয়ার কোনো জায়গাই নেই, লটস অফ ইডিমা এন্ড অল, রাইট? সো আমরা এখানে ট্র্যাকিওস্টমি করব ফার্স্ট, তারপরে আমরা শক ফক যা থাকবে সেগুলো ম্যানেজ করব. ম্যানেজ করার পর অ্যাজ সুন অ্যাজ পসিবল আমরা ওটিতে শিফট করব, রাইট? দেন আমরা ব্লিডিং যা আছে সেগুলো সিকিউর করব, রাইট? ব্লিডিং সিকিউর করার পর আমরা সফট টিস্যু ইনজুরি আপাতত রিপেয়ার করব, তাই তো? দেন উইল গো ফর অ্যান ইমেজিং, তাই তো? টু সি এখানে কোন কি কি বনি ড্যামেজ রয়েছে, আদার কি ড্যামেজেস আছে, ইন্ট্রাক্রেনিয়াল হেমারেজ আছে কিনা, এক্সেট্রা এক্সেট্রা. তারপরে আমরা ডেফিনিটিভ ম্যানেজমেন্ট স্টার্ট করব, রাইট? ইনিশিয়াল ম্যানেজমেন্টটা ইয়োর পার্ট. বিং আ গ্র্যাজুয়েট, মেডিকেল গ্র্যাজুয়েট, দ্য ইনিশিয়াল ম্যানেজমেন্ট ইউ হ্যাভ টু ডু. তারপরে তো কনসালটেন্ট আসবে, ওকে? ওকে, দিস ইজ অনেকবার করা হয়েছে. ইটস আ কমপ্লিকেশন অফ সামথিং, তাই তো? একটা স্টেজিং বলেছিলাম, চ্যান্ডলার স্টেজিং. ইটস আ কমপ্লিকেশন অফ এনি acute rhinosinusitis, right? Here it is, patient is having orbital cellulitis, তাই তো? ওকে, this is unilateral, কোয়ানার দিকে যাচ্ছে. It's a polyp, anterochoanal polyp. How will you treat this patient? Excision, the name of the surgery. It's an endoscopic sinus surgery, or ESS or FS. Okay, label করতে পারবি? This is your lacrimal system, drainage system. Superior puncta, inferior puncta, then superior canaliculi, inferior canaliculi, তাই তো? Opening is puncta, then canaliculi, then common canaliculi, then nasolacrimal duct, তাই তো? And it drains into where? Inferior meatus, right? This is a big perforation in your septum. We call it septal perforation. This is again a polyp starting from the maxillary antrum and going towards the choana, তাই তো? So it is anterochoanal polyp. Which sided? Always this is right side, this is left side. Think like that, okay? This is my right side, so that is the right side, okay? So this is left sided, right? This is cleft lip, this is, okay? This is again, get the history first. 50-year-old male, right sided nasal mass, okay? Right sided nasal obstruction, anosmia, right sided diplopia, ophthalmoplegia, and vision is deteriorating. So sinonasal malignancy, right? Aged patient, right? Lots of complication. It's going here and there and everywhere infiltration, and you can see there is a mass here. It's eroding the orbit, it's going into the orbit and other complications. So it's a malignancy, okay? Sinonasal malignancy. What is the most common sinonasal malignancy? Type? Squamous cell carcinoma. Right? Apart from that, we can have other things as well. Adenocarcinoma can be there. Right? Art? Melanoma is also there. I got a patient recently. It's a very rare thing. So malignant melanoma can arise also from this thing. Any other thing? Any other type? Olfactory neuroblastoma or esthesioblastoma, right? এটাও হয়, ওকে? মাইনর salivary gland cancer অনেক হতে পারে, nasal cavity এর মধ্যে হয়, ঠিক আছে? This is দুদিকে both sided পলিপে ভর্তি, ethmoidal polyposis, right? কটা সিনড্রোমের কথা বলেছিলাম আমি। What are those syndromes? কিছু কিছু সিনড্রোমে এক্সটেন্সিভ পলিপোসিস হয়। নেম দোজ সিনড্রোমস, একটা দুটো। হ্যাঁ হ্যাঁ হয়, গার্ডেনার সিনড্রোম। আর তারও আগে আছে সিস্টিক ফাইব্রোসিস, কলম্যান সিনড্রোম, ঠিক আছে? দেখতে পাচ্ছ মারামারি করেছে। অ্যান্ড ক্রুক ডিফর্মিটি, ইটস নট ডিএনএস। এটা কি নেজাল সেপ্টাম নাকি? ডিএনএস মানে কি? ডিভিয়েটেড নেজাল সেপ্টাম। এটা নেজাল বোন ফ্র্যাকচার, রাইট? ফ্র্যাকচার হয়ে ডিপ্রেসড হয়ে গেছে, দ্যাট ফ্র্যাকচার ফ্র্যাগমেন্ট, রাইট? How will you manage this case? Nasal bone fracture? Any fracture management, what is the basic principle? You have to reduce the fracture, তাই তো? Reduce the fracture and fix it. যদি আমরা ওপেন করে ফিক্স করি, that is open reduction. যদি বাইরে থেকে ফিক্স করতে পারি ম্যানিপুলেশন করে, that is closed reduction. Ultimately আমাকে ফিক্স করতে হবে তারপর, তাই তো? So mostly if it is a fresh case, then we can go for a closed reduction, তাই তো? ইনস্ট্রুমেন্টের সময় দেখাবো কোন ইনস্ট্রুমেন্ট দিয়ে করা হয়। ক্লোজ রিডাকশন করার পর আমরা এখানে জেনারেলি একটা প্লাস্টার দিই, তাই তো? কমার্শিয়ালি অ্যাভেলেবলও রয়েছে থার্মোপ্লাস্টিক স্প্লিন্ট, ওকে, অ্যালুমিনিয়াম স্প্লিন্টস লাইক দ্যাট, বা প্লাস্টার অফ প্যারিস দিয়েও আমরা একটা প্লাস্টার দিতে পারি, তাই তো? তার আগে কি করতে হবে? পেশেন্টের দেখে নিতে হবে নাকের ভেতরে কোনো মেজর সেপ্টাল হেমাটোমা বা ট্রমা এপিস্ট্যাক্সিস আছে কিনা, তাই তো? তাহলে সেটা ম্যানেজ করতে হবে। ফার্স্ট কামস ফার্স্ট, এনি পেশেন্ট কামস ফার্স্ট এয়ারওয়ে, তারপরে কোনো ব্রিদিং সার্কুলেশন সব দেখে কোনো ব্লিডিং এর সোর্স আছে কিনা, সেগুলো অ্যাকিউট ম্যানেজ করার পর তারপরে আমরা এটা করতে পারি। যদি ইফ ইট ইজ এন ওল্ড ফ্র্যাকচার 20 ডেজের বেশি হয়ে গেছে, অলরেডি হিল করে যাবে এইভাবে, তাহলে আমাকে কি করতে হবে? আবার রিফ্র্যাকচার করতে হবে, করে সেট করতে হবে, তাই তো? আরো ওল্ড ফ্র্যাকচার, অনেক বেশি ওল্ড ফ্র্যাকচার, রিফ্র্যাকচার সেভাবে করা যাচ্ছে না, তাহলে আমাদেরকে ওপেন করতে হবে, ওপেন করে ওপেন রাইনোপ্লাস্টি করতে হবে, রাইট? ফ্রেশ কেস আমরা ক্লোজ রিডাকশন করতে পারি। সো দ্য টেক হোম মেসেজ হচ্ছে, ফ্রেশলি you have to tell the patient that get it done when it is fresh, right? Here also there is a deformity, saddle nose deformity, right? Here is also, what is this picture? ডান দিক না, এটা বাঁ দিক না ডান দিক? লেফট। There is an opacity, soft tissue opacity, normally black color হয় because sinus normal content কি? Air is black, তাই তো? If there is any soft tissue, then you will get this kind of picture. So it's a polypoidal mass, a soft tissue density that is going towards choana. So it's another case of anterochoanal polyp. Here you can see here, this is the nasal septum. Can you see there is a sharp division here? That is septal spar, okay? And little bit of collection is there. Is it polyp? No. It's basically mucus collection, mucositis and little bit of edema because of that, okay? Here is also, this is the choana, right? This is your nasal cavity, this is your oropharynx, and this is the choana. Choana means what? Nasal cavity posteriorly যেখানে open up করে, তাই তো? That is choana. You can see the choana is blocked bilaterally, তাই তো? So there is this white thing is bone and little bit blackish, this thing soft tissue is soft tissue, right? So it has been blocked with both the soft tissue and bone, right? This condition is choanal atresia. Right? Bilateral choanal atresia is a dangerous thing. Newborn baby নিঃশ্বাস নিতে পারছে না, আগের দিনও বলেছিলাম, তাই তো? Unilateral choanal atresia patient babies will survive, but bilateral will not survive until you quickly recognize it and do the intervention, because babies are mostly nasal breather. Okay, they are compulsory nasal breather, মুখ দিয়ে নিঃশ্বাস নিতে পারে না। নাক যদি ব্লক থাকে তাহলে what you have to do? You have to break it as fast as possible, right? So that the baby can survive. And if there is very heavy, I mean large thickness bone only, that is bony choanal atresia, then the baby is difficult to make him alive, right? Make him live. So these are the things, okay? So next class I will talk about head and neck. I mean mostly your tonsil, larynx, pharynx, thyroid, salivary gland, all these things, right? Okay.